Hello, my name is Gabriel Soriano. My topic is Rivaroxaban in peripodotary disease after vascularization. My teacher is John Moscoso. Introduction. Peripodotary disease is a common disease affecting over 200 million people globally. Those manifestations primarily in the lower limbs, the underlying disease in systemic atherosclerosis, which is association with a heightened risk of atherothrombosis, and therefore systemic vascular prevention strategies are essential.
Dr. Sonia Anand, steering committee member of the COMPASS trial, who led the peripheral artery disease component of the trial. There were 7,410 patients randomized into the COMPASS trial who had peripheral artery disease. These patients were defined based on a past history of peripheral artery disease, including surgery or prior amputation, a history of intermittent claudication with objective criteria defining PAD, as well as carotid arterial disease and coronary artery disease with a low ABI. This PAD cohort, like the overall COMPASS trial, were randomized to receive one of three treatments: Rivaroxaban 2.5 milligrams twice daily plus aspirin, or Rivaroxaban alone 5 milligrams twice daily, or aspirin alone 100 milligrams per day. The primary MACE outcome, major adverse cardiovascular events, included the composite of cardiovascular death, MI, and stroke. We observed this was significantly reduced in patients receiving Rivaroxaban and aspirin combination compared to aspirin alone, with a hazard ratio of 0.72, equivalent to a 28% relative risk reduction, which was very statistically significant. On the other hand, there was no reduction observed for patients receiving Rivaroxaban alone as compared to aspirin. Of interest to PAD patients are major adverse limb events. Our primary major adverse limb event, known as MALE, was severe limb ischemia events leading to an intervention, as well as major amputation due to a vascular cause. We observed that major adverse limb events were significantly reduced by the combination of Rivaroxaban and aspirin as compared to aspirin alone, with a relative risk reduction of 46%, which was highly statistically significant. On the other hand, a borderline reduction in major adverse limb events was observed with Rivaroxaban alone as compared to aspirin. When we combine all major adverse cardiovascular events and all major adverse limb events, we observe a significant 31% relative risk reduction in favor of the Rivaroxaban and aspirin combination compared to aspirin alone. There was an increase in major bleeding with the Rivaroxaban and aspirin combination compared to aspirin alone, with a 1.66 relative risk increase in major bleeding. The criteria to define a major bleed was the modified ISTH criteria. Importantly, no increase in fatal or non-fatal intracranial hemorrhage or symptomatic bleeding into a critical organ was observed with the combination of Rivaroxaban and aspirin compared to aspirin alone, and the majority of bleeds were less severe and treatable. So in summary, the net clinical benefit of aspirin and Rivaroxaban used together is in favor of that combination in reducing major adverse cardiovascular events, major adverse limb events, including major amputation, as the rates of fatal or non-fatal serious critical organ bleeding were very low. So the summary is that Rivaroxaban 2.5 milligrams twice daily plus aspirin may be an important therapy for the treatment of patients with PAD in the future.
Patients with peripodotary disease who have undergone lower extremity revascularization are at high risk for major adverse limb and cardiovascular events. The efficacy and safety of Rivaroxaban in this context are uncertain.
It could be peripheral artery disease. In tonight's medical moment, Derek Francis explains the warning signs and the dangers if left untreated.
Peripheral artery disease, or PAD, is a circulatory problem in which narrowed blood vessels reduce blood flow into the limbs.
Those blood vessels can build up with cholesterol inside them, and they start to narrow and decrease the amount of blood flow that's getting to your muscles or to the tissues of your feet and legs.
Many people never have symptoms. Others have subtle ones.
Subtle signs are if you have a decrease in the amount of hair that's growing on the lower aspects of your legs, that can sometimes be a sign. Or if you just notice your feet are cool or discolored all the time. For a lot of people, the symptom is as simple as pain or their legs getting really tired early on when they walk or climb stairs, do activity. Their muscles just aren't getting the blood and oxygen that they need. More advanced symptoms of PAD are starting to develop sores or ulcers on your feet or legs. Or if you do get a cut, it just doesn't heal as quickly.
When left untreated, PADs can lead to tissue damage and other serious problems, and Dr. Yasa says that PAD is often a sign of something worse.
If they have arterial disease in the blood vessels of the legs, they're likely to have blood vessel disease in the blood vessels around the heart.
Once a person hits 50, the rate of PAD goes up, but for people at high risk, it can start much sooner.
Those are really the big risk factors: the smoking, high blood pressure, obesity, and high cholesterol. The good thing about those things is that most of them are things that we can modify if we catch them early on.
Some PADs can be treated with medication and lifestyle improvement, while others require surgical procedures.
The other surgical options are things like balloons or stents, and that's that minimally invasive surgery that we talked about, where we go into the artery with just a small poke or a needle. We take some pictures of the blood flow, and sometimes right then and there we can make the blood flow better.
The most serious require a bypass, not unlike the procedure we know with heart disease.
Bypasses can be used in all sorts of places in the body to get around blocked blood vessels, where we actually detour around the blocked blood vessels to bring blood down to the foot through something else like a vein or a piece of graft.
Dr. Yasa says the easiest way to stay ahead of peripheral artery disease, a simple screening, which is often covered by your insurance. Derek Francis, Fox 17 News.
Well, we've got more snow on.
Pros and cons. Pros. May consider use in careful select patients who are at a high risk of cardiovascular events and low risk of bleeding if therapeutic anticoagulation or dual antiplatelet therapy is not required for another indication. Cons. Premature discontinuation increases the risk of thrombotic event.
Oral factor Xa inhibitors are a recent hot item. Dabigatran has just been approved for stroke prevention in patients with atrial fibrillation, and now in the New England Journal of Medicine, there is news that Rivaroxaban is useful for symptomatic venous thromboembolism. The report was actually about 2 studies done in parallel. In the first, Rivaroxaban was compared to subcutaneous enoxaparin, followed by warfarin or dicumarol. In the second, Rivaroxaban or a placebo was continued after 6 to 12 months of treatment were over. The outcome being recurrent embolic events for both studies. In the head-to-head comparison with anticoagulation with warfarin, Rivaroxaban was non-inferior with respect to the primary outcome, but Rivaroxaban in the second study was also superior to placebo. Remember that Rivaroxaban is a once-daily pill that does not require monitoring. Now it's been shown to offer a simple approach to short-term treatment of venous thromboembolism and a superior continued treatment strategy rather than simply stopping anticoagulation. I'm Peter Block with a CardioSource Heart Minute.
Used applied in Ecuador. Peripavascular disease affects more than 2 million people in Ecuador. It is a marker of systemic atherosclerosis and in many cases great limitation to daily life. This group of patients is at high risk of suffering ischemic events of all kinds.
At the International Stroke Conference, Dr. Graham Henke reported that Rivaroxaban, a new generation anticoagulant, decreased the risk of intracranial bleeding by 40% compared to warfarin. His sub-analysis of the ROCKET atrial fibrillation study found that the drug, a factor Xa inhibitor, was significantly safer than warfarin with respect to brain bleeds. Dr. Henke said Rivaroxaban offers some advantages over warfarin.
We now have a medication such as Rivaroxaban and the other two new oral anticoagulants that have predictable anticoagulant effects, don't require them monitoring, and importantly, don't have the food interactions that warfarin has and have very few drug interactions.
Dr. Jose Biller said the drug's promising, but not necessarily a one-size-fits-all treatment.
Well, this is a very promising agent and is an additional agent to the novel armamentarium with anticoagulants. I would say that as yet, it would be premature to make a strong recommendation. Certainly, we have more agents to use in our patients, but I would not jump to the conclusion that this is an indication to shift to the factor Xa inhibitors or the direct thrombin inhibitors. Has to be very selected case by case.
Conclusion. In patients with peripheral arterial disease who have undergone lower extremity revascularization, Rivaroxaban at dose of 2.5 milligrams twice daily plus aspirin was associated with a significantly lower index of the composite outcome of acute limb ischemia, major amputation for a vascular cause, myocardial infarction, ischemic strokes, or death from cardiovascular cause than aspirin alone.
Anticoagulation of vitamin K antagonists has well-known limitations and requires routine clinical monitoring of coagulation parameters. The new oral anticoagulants represent novel direct-acting inhibitors of the coagulation factors 2A thrombin or XA. The compound with the currently widest clinical approval for oral anticoagulation in the group of the XA inhibitors is the direct oral factor XA inhibitor, Rivaroxaban. Rivaroxaban was the first direct factor XA inhibitor with clinical approval for long-term oral anticoagulation in patients with non-valvular atrial fibrillation and has since gained additional approval for the treatment and prevention of deep vein thrombosis and pulmonary embolism. Furthermore, low-dose Rivaroxaban, in addition to standard antiplatelet therapy, has been shown to reduce cardiovascular mortality in patients following a recent acute coronary syndrome and recently gained approval for the prevention of atherothrombotic events after acute coronary syndrome by the European Medicines Agency. This review article discusses the clinical use and benefits of Rivaroxaban for multiple indications. If you like the sound of this article, view the full journal via our website at www.emjreviews.com.